To thank my friend Dr. Yogesh Shastri and the entire organizing team of the 8th International Conference on Gastroenterology and Therapeutic GI Endoscopy. I'll be speaking on the topic of EUS-guided liver biopsy, an overview. Liver biopsy continues to remain the gold standard for several liver disorders. The others which have come very close to it is elastography and looking at the metabolites, but they can at best be called silver standard and not gold standard. So liver biopsy remains the gold standard. So when do we consider a patient for liver biopsy? Whenever he has an abnormal LFT and the investigations following the guidelines from several societies exclude a biliary obstruction as a cause of it. And if the focus is towards the liver dysfunction because of hepatocytes or the intrahepatic canalicular problems, then we start suspecting an organic liver disease, and such are the patients who require liver biopsy. And how do we do a liver biopsy? There are several methods to do, that is by EUS-guided, percutaneous, and transjugular. So which route to decide for EUS-guided liver biopsy? We have three common routes available. Percutaneous has been a traditional method of liver biopsy. It's simple and inexpensive, whereas transjugular is considered when a patient has thrombocytopenia or coagulopathy. It also measures the portal pressure measurement. But the drawback of percutaneous is patient discomfort, higher complication rates, only right lobe is accessed, sampling error, fewer passes are required, and also difficult in patients who are obese, in children, pregnant, or patients who have an overlying bowel gas between the liver and the surface of the skin. Whereas the disadvantage with transjugular is need of fluoroscopy, that is radiation, incision in the neck to pass the catheter to reach that right hepatic vein, patient discomfort, and it's more expensive. And that's where EUS-guided comes into play. So why EUS-guided liver biopsy? 4 major reasons is it's safer, it's clinically efficacious, better patient experience, and its benefit to the GI department who's performing the liver biopsy. Obviously, within these subcategories, there are reasons for that which are written here, but the broader category is safety, clinical efficacy, better patient experience, and the benefit to the unit. Also, we see the liver anatomy optimally. Both the left lobe and the right lobe can be seen, the left from the stomach and the right lobe through the duodenum. You visualize real-time puncture of the liver. We see everything live. And that's a major advantage compared to other methods of liver biopsy where other imaging methods are used. How has liver biopsy by EUS progressed over a period of time? The first report came in 2002, but the first adequate specimen was obtained in 2007 by EUS-guided liver biopsy. And for the last 5 to 10 years, there has been a tremendous publications in this front. Adequacy of liver biopsy was shown by 19-gauge FNA needle in 2012. David Dale gave a very important paper in 2015 in EIO with multicentric study on EUS-guided liver biopsy with high specimen adequacy in more than 100 patients. In 2018 to 21, we saw 3 RCTs comparing 19-gauge FNA with FNB needle, wet heparin with dry suction, and single pass with 1 versus 3 needle actuation. And the most recent report came that also you can do liver biopsy with EUS-guided portal pressure measurements. So what are the strategies? When we do a liver biopsy by EUS, we have to decide which method to use, aspiration or biopsy, which needle to choose, and which make is preferred. So let's discuss all these issues one by one. Regarding the needle size, the publication in 2017 in GI Endoscopy showed that the biopsy needle is better than the FNA needle. Then there was a publication in 2019 from an Endoscopy which showed that FNB needle was better than the FNA needle of 20 gauge, and Francine was better than the conventional FNA needle. Also, the longer specimen length and more complete portal tracts were obtained with the FNB. Then there was another publication in 2021 in surgical endoscopy, which was a meta-analysis of 23 studies of more than 1,300 patients, and it showed the biopsy needles fared better than FNA for the complete portal tracts. So net, we now know that biopsy is better than the aspiration needle. So if you have to do a liver biopsy, use a core biopsy needle of EUS type. Which gauge to select? And this was a publication in 2019, again the bovine models, and they found that 19 gauge was superior to the 22 gauge. Then EIO paper of 2018 showed that the 19 gauge FNA was better than 22 gauge FNB. Let me repeat, a 19 gauge FNA is better than 22 gauge FNB. Fragmentation was also higher in 22 gauge FNB needle, and the specimen adequacy is higher with a larger caliber needle. Same goes with the publication in 2020 from Prashant Kedia and group, where they showed that 19 gauge FNB needle versus 22 FN gauge needle, the complete portal tracts were much superior in the higher gauge needle. Same was the specimen adequacy. So it shows that the higher gauge needle, even if it's FNB, is better than the 22 gauge. So 19 is better than 22 gauge FNB needles. So which needle type? There are several types of the FNB needle. The Procord, which is a side hole, is inferior to the 19 gauge regular FNA, which is also inferior to the Francine needle, which is almost equivalent to the fork tip. So the last two types are almost equivalent in tissue acquisition, number of portal tracts, and tissue adequacy. And this has been published in several papers, as mentioned on the right of the slide. So how do we get the tissue into the hollow of the needle? There are several methods also described here, just like FNA, the dry needle method, the dry heparin method, where you just flush heparin through the hollow of a needle and put it inside the liver. The wet heparin method, where you keep the whole hollow of the needle wet with a wet heparin and then slowly pull back with a negative suction. And the slow stylet method, which is also used for the regular FNAs. Overall, all the methods are good, but the wet heparin method, the number 3 from top, is supposed to be the best. And heparin priming does not alter the interpretation of tissue cytology or immunohistochemistry. This was a publication which compared wet and dry heparinized suction. And if you see, there were 3 arms, the dry control, the dry heparin, and the wet heparin method. And the last column shows the best results are with adequacy is best with the wet heparin, so was the portal tracts, and so was the total specimen length, and even the visible clots were the least in the wet heparin. So don't worry about heparin in the solution, it won't cause any extra bleed. This was a randomized multi-center study from US, and this compared the wet suction with the slow pull method. And you see the wet suction method has the higher total specimen length, the longest specimen length was also bigger, the portal tract numbers were also much higher, the complete portal tracts, and the biopsy time was almost equivalent. So if you have to do biopsy from the liver, use a wet suction method, preferably a heparin method. What about the number of actuations? Actuation is when you pass the needle inside the tissue and move once. If you move it twice or thrice, that's called 2 actuations or 3 actuations. So on the left panel, you see 1 pass made and only 1 actuation made. This was 165 patients with a shark core needle of 19 gauge. The total specimen length was very good, 6 centimeters, and the complete portal tracts was 18. The actuation length also was very high. Normally about 3 centimeter actuation length is good enough, but if you can go deeper without injuring any blood vessels, you can go. But this had a 7 centimeter actuation, which is phenomenal. On the right panel, a publication which came last year, which compared 1 actuation in pass or 3 actuation in a single pass. And this was a prospective RCT of 40 patients. The total specimen length was 6.89 in the 1 actuation versus almost double in 3 actuations. And so was the increase in the number of the complete portal tracts when you increase the number of actuations. The adverse events remain similar. So if you have to do a liver biopsy, make 1 or 2 passes and use at least 3 actuations to get the best yield in each pass. This is our own publication which has just got accepted few days back of comparing whether left lobe liver biopsy is safe. So we found that EUS-guided liver biopsy from left is as good as a right lobe. So what is already known? There is some sampling variability exists. Disease such as NASH are unevenly distributed. Negative predictive value of a single biopsy in diagnosing NASH in 0.74 discordance is also there between right and the left lobe. So what about bilobar liver biopsy with EUS? Does it enhance the assessment of disease severity in a patient with NASH? So this is a retrospective data of 38 patients where the agreement between the right and the left lobe was moderate for lobular inflammation and fibrosis. Only right lobe assessment underestimated the fibrosis in 1/5. It underestimated the inflammation in about 13% and steatosis in 8%. So some of the disease may not have an equal distribution, although they have a diffuse disease, and hence some people suggest that both lobes should be accessed at the liver biopsy. So they can be sampled, and depending on the convenience and the capability, you can pick and choose. So in summary, what I've said so far is that 19 gauge needle is a preferred needle. Use an FNB needle and not an FNA needle. A wet suction with heparin is preferred. Make 1 or 2 passes and use 2 or 3 actuations in each pass. Bilobar can be done if indicated. Moving forward, how do we do liver biopsy by EUS? So there is pre-procedure workup quite similar to what we do in the percutaneous liver biopsy. And also there's some preparation that patient has to be fasting. Blood thinners have to be avoided. And conscious sedation is used in such patients just like we do in any other EUS procedure. Look at the left panel. This is a picture of EUS FNB being done from the left lobe. The operator standing straight in a relaxed position. But sometimes from the right lobe, if you have to go in a very awkward position which can put strain on your back, shoulders, wrist and fingers. And even the tissue acquisition may not be very adequate. So a left lobe versus right lobe, left lobe is much easier to do. You straight away see the left lobe as soon as you enter the... So how do we do liver biopsy? This is the liver coarse ecotexture of the liver as you can see on the screen. You mark the needle path, which is avascular, after applying Doppler, and then pass the needle inside. As soon as you enter the needle inside the liver capsule, you apply the suction at the other end of the needle and go inside in different path. These are actuations. The third actuation. The whole length of the needle is visible. You don't have to cross the capsule of the liver. This is the fourth actuation in this pass. And as you come back, you can apply a Doppler to see the tract, which I'll show in the next slide. And once you apply Doppler at the time of removal of needle, sometimes you see a red track, which is actually the blood flowing in the path where the needle traversed. And these tracks suggest that bleeding is likely to happen from the capsule. And if you see it's persisting for at least 30 seconds or more after withdrawing the needle till the capsule, then you can stop there, keep the needle inside and wait for these red signals to go away. If they continue for at least 2 minutes or more, then the risk of bleeding is even higher. And then at that point, you can actually expel out some of the tissue back in the tract, which works like a blood patch technique. Let me show you in a video here. This is the path which the needle traversed. And as we withdraw and apply a Doppler, you can see the red line, which means the blood is flowing in this path of the needle. And before you withdraw completely from the capsule of the liver, we keep the tip of the needle inside and expel a small amount of blood and the tissue out, which works like a procoagulant state. This white area is the expelled material and the bleeding would stop right there itself. It will not reach the capsule. So this is a blood patch technique where the blood itself is used as a procoagulant. Once we have taken the tissue, we expel it out on the slide. And gently expulsion by the stylet is preferred. and then you can separate out the blood from the liver tissue. And if you have a sieve-like container, this is even better, which you can visualize it. And if you keep a scale below, you can actually measure the length of the entire specimen obtained. So tissue obtained can also be seen against the light, and you can see brownish material is the liver tissue and the red is the clot, which in low power also can be visible. So tissue yield is adequate when the specimen length is at least 15 to 20 millimeters and the portal tracts at histology is more than 11. And in this paper of David Dale, which is a landmark paper of 110 odd patients, the pathological diagnosis could be established in about 98% of the patients, which had significant aggregate length of 38 millimeters. So was the publication over here, which showed that the tissue length was 45 and the complete portal tracts could be seen at least 15 or more. What's a comparison of EUS-guided liver biopsy with percutaneous liver biopsy? In this paper, which had 3 groups, the EUS group gave the maximum length of the tissue. So was the complete portal tracts were the highest in the EUS group. So how does EUS compare with percutaneous in randomized control trial? This is a publication which came from Shyam's group with G. Young Bang as a first author in Gut last year, where they compared RCT of liver biopsy by EUS versus percutaneous liver biopsy in 21 cases in the EUS arm and 19 in the percutaneous arm, and they found that the maximum length of the biopsy specimen and the optimal biopsy specimen was better with the percutaneous compared to the EUS arm. So in this paper, percutaneous was found to be superior than the EUS arm. We had our own publication this year, presentation in DDW this year with the PGI group. And we found that comparing a liver biopsy by EUS compared with percutaneous, the specimen adequacy was better with EUS, so was the aggregate specimen length, and so was the number of portal tracts. So EUS liver biopsy is not inferior to percutaneous biopsy. And the most recent data which has come this year, which compares EUS liver biopsy with percutaneous, shows that almost the specimen length is equal, and so is the number of the portal tracts. What are the adverse events of EUS-guided liver biopsy? They're quite similar overall compared to the percutaneous, but when percutaneous we have more of pain because you go through the skin, which is the pain sensitive area, unlike the EUS-guided. Bleeding which is reported with percutaneous is much higher in about 11%, with a major bleed in about 5% patients with percutaneous liver biopsy, whereas EUS-guided liver biopsy, the bleeding is much lesser and also insignificant. Plus, we can see it live in real time while doing liver biopsy, and we can take action to prevent it, which is not possible often with percutaneous liver biopsy. Other complications with percutaneous include pneumothorax, hemothorax, biliary peritonitis, and tumor seeding, which are not known with EUS-guided liver biopsy. Also, the patient need not lie down on the right decubitus for more than 2 to 4 hours, which is required for percutaneous. In EUS-guided, he can lie supine or on either side and can go on the same day home. So net, the tissue yield is almost equal with percutaneous and EUS-guided liver biopsy. Pain is very less with EUS-guided compared to the percutaneous. Bleeding is higher with percutaneous. However, the costs are higher currently because of the needle involved in the EUS arms. Who are the best candidate for the EUS-guided liver biopsy? The patients who need liver biopsy along with other upper GI procedures, who need sedation, who need bilobar biopsy, who also needs EUS evaluation for other illnesses like biliary and pancreas and vessels, and also need for a portal pressure measurements. The contraindications remain more or less the same, like percutaneous, thrombocytopenia, coagulopathy, and gross ascites. However, EUS-guided biopsies can be done in patients who have mild ascites. So EUS can be a one-stop shop for endohepatology. For endohepatology, not only you can do EUS biopsies, but you can also see for varices. You can intervene in these varices. You can do portal pressure measurements, and so on and so forth. So in the end, I would like to conclude by saying that EUS liver biopsy is safe and is equivalent to percutaneous liver biopsy. EUS FNB needle with a wet suction yields a good tissue. However, more data is needed in this front. and should be considered over percutaneous in patients who need endoscopy for other reasons, exclusion of biliary obstruction, measurements of portal pressure gradient, or those who need bilobar biopsies, or even very anxious patients. Thank you very much for your kind attention.